Substance use disorders are a national problem. More than 16.6 million adults and 697,000 adolescents in the United States have an alcohol use disorder. 14% of adults report binge drinking in the last month. Around 88,000 people die from alcohol-related causes each year, and alcohol-related death is the third leading preventable cause of death in the United States. The actual prevalence of substance abuse is difficult to determine, as many people who meet the criteria for a diagnosis do not seek treatment. There are many detrimental effects of substance abuse, including cost to business, absenteeism, car accidents and fatalities, prenatal exposure for infants, and an increase in violence. Around 8.7 million children live with a parent who has a substance use disorder in any given year. Children of alcoholics are 4 times more likely to develop problems with alcohol than those in the general population. We also have an increased use to opiates in the United States, causing an opiate crisis. In this country, we have about 130 deaths each day from an opiate overdose. Some important terms to know. Substance abuse is using a drug in a way that's inconsistent with medical or social norms and despite negative consequences. Substance dependence includes problems associated with addiction such as tolerance, withdrawal, and unsuccessful attempts to stop using the substance. Intoxication is the use of a substance that results in maladaptive behavior. Designer drugs are synthetic substances made by altering existing medications or formulating new substances not yet controlled or regulated by the FDA. Most are amphetamine-like stimulants, and some have hallucinogenic properties. They may have fillers or additives, and the effects are unknown until it's ingested. This includes bath salts, ecstasy, Special K, and smiles. Withdrawal syndrome is negative psychological and physical reactions that occur when the use of a substance ceases or dramatically decreases. Detoxification is the process of safely withdrawing from a substance. Polysubstance abuse is the abuse of more than one substance. And codependence is a maladaptive coping pattern on the part of family members or others that results from a prolonged relationship with the person who uses the substances. There are many types of substances that can be abused. The categories include alcohol, sedatives, hypnotics, and anxiolytics, stimulants, cannabis, opioids, hallucinogens, and inhalants. In the U.S., the average age for the initial alcohol intoxication episode is in the teenage years. For those who develop alcoholism, the initial intoxication is typically between 12 and 14 years of age. They go on to have more problems due to alcohol use, maybe a breakup, arrest, problems at work or school that are alcohol-related, and even early alcohol-related health problems. As the person continues to drink, they develop a tolerance for alcohol and may have a tolerance break. As alcoholism continues, the person's functioning is affected. They may even have periods of abstinence or controlled drinking, but that leads to an escalation of alcohol intake, more problems, and finally, a crisis. The cycle continues to repeat itself. As a nurse, it's important to note that alcoholism is a chronic illness, that patients will have both remissions and relapses. Nearly half within a year of treatment. The highest rates of recovery come from those who abstain from any substance use, are highly motivated to live a substance-free lifestyle, and actively work on relapse prevention. Related disorders include gambling disorder and caffeine and tobacco addictions. We don't know exactly what causes drug use, dependence, and addiction, but we do have some theories. The biologic factors include genetics and neurochemical influences. Children of alcoholic parents are at a higher risk for developing alcohol dependence and drug dependence. Studies have shown that the genetic component of alcoholism is a genetic vulnerability that can be influenced by social and environmental factors. Neurochemical influences center on dopamine, which produces a pleasant feeling or a high feeling. It's thought that some people have an internal alarm that limits them to 1 or 2 drinks in order to get the pleasant feeling and go no further, while those without the internal alarm feel an initial high but continue to drink until they're intoxicated. Psychological factors include family dynamics and coping styles. As stated previously, children of alcoholics are 4 times more likely to develop alcoholism. It's thought that poor role modeling and a lack of nurturing introduce a child to that lifestyle. Children in this situation may also not develop adaptive coping skills or form successful relationships. Social and environmental factors include social attitudes, peer behavior, law, cost, and availability. Younger experimenters will usually choose substances that have less social disapproval, like alcohol or cannabis, while older people may choose drugs like cocaine or opiates. When alcohol costs more, consumption decreases. When it's readily available, consumption increases. Attitudes about substance use vary from culture to culture. Muslims do not drink alcohol, whereas Jews use wine as an integral part of religious rites. Some Native American tribes use peyote as part of religious ceremonies. The Japanese do not consider alcohol to be a drug, and there aren't any religious prohibitions on drinking. Some ethnic groups have traits that either predispose or protect them from developing alcoholism. There can be variants in the enzymes that are involved in the metabolism of alcohol. An example of this is flushing. Alcohol abuse is one of the 5 leading causes of death for Native Americans and Alaska Natives. 1/8 of Native Americans are identified as needing treatment for alcohol or drugs. Alcohol is a central nervous system depressant and is rapidly absorbed into the bloodstream. Initial effects include relaxation and a loss of inhibitions. Signs and symptoms of intoxication include slurred speech, unsteady gait, lack of coordination and impaired attention, concentration, memory, and judgment. Some may become aggressive or sexually inappropriate. Signs and symptoms of an alcohol overdose include vomiting, unconsciousness, and respiratory depression. Treatment of an overdose can include gastric lavage or dialysis and supporting the respiratory and cardiovascular systems, probably in the ICU. Withdrawal from alcohol. The symptoms usually appear 4 to 12 hours after cessation and include coarse hand tremors, sweating, elevated pulse and blood pressure, insomnia, anxiety, and nausea or vomiting. Severe or untreated withdrawal may have transient hallucinations, seizures, or delirium, which is called delirium tremens or DTs. Withdrawal usually peaks on the 2nd day and is over in about 5 days, although this can vary. Withdrawal from alcohol can be life-threatening. Because alcohol withdrawal can be life-threatening, it needs to happen under medical supervision. If the withdrawal symptoms are mild, the person can probably be treated at home, but if they're severe, the person will likely need to be treated in an inpatient setting. If admitted, the stay in the hospital is usually 3 to 5 days. There's some medications to help with alcohol withdrawal. Benzodiazepines, such as lorazepam or Ativan, or chlordiazepoxide or Librium, can both help. Librium is frequently used as a Librium taper, while Ativan is frequently used based on a CIWA, or Clinical Institute Withdrawal Assessment for Alcohol scale. There's an example of a CIWA scale in your book in box 19.2. Sedatives, hypnotics, and anxiolytics include barbiturates and benzodiazepines, which are the most commonly abused in this category. The effects, symptoms, and withdrawal are similar to alcohol. We even use the CIWA scale. A benzo overdose is rarely fatal, but the person will be lethargic and confused. Treatment may include tapering, activated charcoal, a saline cathartic, or dialysis if symptoms are severe. Barbiturates can be lethal in overdose and can cause coma, respiratory arrest, cardiac failure, and death. Treatment occurs in the ICU with lavage or dialysis and respiratory or cardiac support. Stimulants are drugs that stimulate or excite the central nervous system and have limited clinical use except to treat ADHD. They include amphetamines, cocaine, and methamphetamines. Methamphetamines are the most dangerous. They're highly addictive and can cause psychotic behavior or brain damage. Intoxication happens rapidly. Feeling high or euphoric, hyperactivity, hypervigilance, talkativeness, anxiety, grandiosity, hallucinations, anger, fighting, and impaired judgment. Physiologic symptoms include tachycardia, elevated blood pressure, dilated pupils, perspiration, chills, nausea, chest pain, confusion, and cardiac dysrhythmias. Overdose can cause seizures and coma. Death is rare. Treatment includes chlorpromazine or thorazine, which controls hallucinations, lowers the blood pressure, and relieves nausea. Withdrawal happens in a few hours to a few days and is not life-threatening. The person may experience marked dysphoria, fatigue, vivid or unpleasant dreams, either insomnia or hypersomnia, increased appetite, and psychomotor retardation. Cannabis is the hemp plant that is used for many things. Marijuana refers to the upper leaves, flowering tops, and stems of the hemp plant. It's usually smoked in joints but can be eaten. The legal status of cannabis is changing in the United States. While federal law still considers most cannabis use illegal, some states have legalized medical marijuana, recreational use, or both. Cannabis begins to act less than 1 minute after inhalation, peaks in 20 to 30 minutes, lasts 2 to 3 hours. Signs and symptoms include feeling high, lowered inhibitions, relaxation, euphoria, and increased appetite. Symptoms of intoxication are impaired motor coordination, inappropriate laughter, impaired judgment and short-term memory, distortions of time and perceptions, anxiety, dysphoria, and social withdrawal. Physiological effects include bloodshot eyes, dry mouth, hypotension, and tachycardia. Excessive use can cause delirium or cannabis-induced psychotic disorder. There is no significant withdrawal, although some report muscle aches, sweating, anxiety, and tremors. Opioids include meperidine or Demerol, morphine, codeine, hydromorphone, oxycodone, methadone, oxymorphone, hydrocodone, heroin, normethadone, and fentanyl. It's often illegal to get the drugs, and the person may engage in illegal activities to get the drug. Healthcare workers may write prescriptions for themselves or divert drugs. Intoxication develops soon after the initial euphoric feeling, and signs and symptoms include apathy, lethargy, listlessness, impaired judgment, psychomotor retardation or psychomotor agitation, constricted pupils, drowsiness, slurred speech, and impaired attention and memory. Severe intoxication includes coma, respiratory depression, pupillary constriction, unconsciousness, and death. Treatment for overdose is naloxone or Narcan, which is an opioid antagonist, and it reverses all signs of opioid toxicity. It can be given every few hours until the opioid levels drop to non-toxic, which may take days. The onset of withdrawal depends on the drug used. Heroin is typically in 6 to 24 hours, while methadone is 2 to 4 days. Signs and symptoms include anxiety, restlessness, aching back and legs, cravings, nausea, vomiting, dysphoria, lacrimation, rhinorrhea, sweating, diarrhea, yawning, fever, and insomnia. Symptoms cause distress but do not need medications, although you may see clonidine or catapres used along with dicyclamine or bentyl and loperamide or Imodium. Clonidine is used to help reduce anxiety, agitation, muscle aches, sweating, runny nose, and cramping. It does not help reduce cravings. Methadone or buprenorphine Suboxone may be used as a substitute for heroin. It requires a doctor to be licensed to prescribe, and not everyone carries it, so it can be very difficult to arrange for follow-up. Hallucinogens distort the user's perception of reality and produce symptoms similar to psychosis. Intoxication is marked by maladaptive behavior and psychological changes. Anxiety, depression, paranoia, ideas of reference, fear of losing your mind, and potentially dangerous behavior. Physiological symptoms include sweating, tachycardia, palpitations, blurred vision, tremors, and lack of coordination. While these drugs do not cause death themselves, people have died from related accidents, suicide, and aggression. Treatment is supportive and may require restraints for safety. Hallucinogens do not have withdrawal, but some report a craving for the drug. Hallucinogens can also have flashbacks anywhere from a few months to 5 years after the use of the drug has ceased. Inhalants are a diverse group of drugs that include anesthetics, nitrates, and organic solvents that are inhaled for their effects. Some things people may inhale include glue, gasoline, paint thinner, and spray paint. Intoxication symptoms include dizziness, nystagmus, lack of coordination, slurred speech, tremor, unsteady gait, muscle weakness, and blurred vision. The person may be belligerent, aggressive, apathetic, have impaired judgment, or be unable to function. Acute toxicity can cause anoxia, respiratory depression, vagal stimulation, dysrhythmias, or even death. Treatment includes respiratory and cardiac support. There are no withdrawal symptoms for inhalants, though cravings may be reported. Treatment is based on the concept that addictions are a medical illness that's progressive, chronic, and characterized by remissions and relapses. Up until the 1970s, addiction was viewed as a personal problem, and there wasn't much in the way of treatment. Treatment today is different. Many programs are based on the Hazelden model, which was established in 1949 in Minnesota and has been quite successful. Alcoholics Anonymous, or AA, is a self-help group that was founded in the 1930s that's a 12-step program model for recovery. The steps are in box 19.3 of your book. Treatment may include individual counseling and/or group counseling and can occur in a variety of settings, such as inpatient, outpatient, medical units, or the ER. Pharmacologic treatment may be needed to help withdraw safely from the substance and to prevent relapse. Some medications can be found in Table 19.1 of your book. Meds to focus on are benzos like lorazepam or Ativan, chlordiazepoxide or Librium, or diazepam or Valium. Disulfiram or Antabuse is a deterrent. Acamprosate or Camprol helps to reduce cravings. You may also see meds like folic acid, vitamin B12, or thiamine. These may be prescribed to help replace lost nutrients. Dual diagnosis means that the patient has a substance abuse issue and another psychiatric illness, such as depression, schizophrenia, etc. It's estimated that 50% of those with a substance abuse disorder also have another mental health diagnosis. Traditional treatment may have limited success for a variety of reasons outlined in your book. Studies have shown that successful treatment includes key elements of a healthy, nurturing, supportive living environment, assistance with fundamental changes like finding a job and abstinent friends, connections with other recovering people, and treatment of comorbid conditions. Those with substance abuse problems can show up anywhere in healthcare. A patient may be in for something unrelated, maybe surgery or giving birth, and begin to have withdrawal symptoms. Box 19.4 in your book has a screening tool for substance use. Ask about the patient's history. Those with substance abuse frequently have a family member that uses or some sort of crisis that causes them to seek treatment. General appearance and speech is usually normal, although patients may be disheveled, anxious, apprehensive, or maybe even resentful if someone is pressuring them to get treatment. Patients can have a wide range of mood and affect. They may be sad and tearful, angry, irritable, remorseful, and so on. Some may even be very pleasant, but in denial about their substance use. Thought process is usually pretty normal, but the patient may be in denial about the extent of their substance use and may minimize. They may blame other people or things for their use and insist they can quit on their own. Sensorium and intellectual processes are usually intact unless there are some neurologic deficits from long-term alcohol or inhalant use. Judgment and insight may be fair or poor, as patients may continue to act impulsively. They may still believe that they're able to control their substance use, and they may not see the loss of jobs or relationships as connected to their substance use. Patients generally have a low self-esteem and don't feel that they can cope with stress and life without the use of substances. They may struggle to identify and express their feelings. Roles and relationships are strained. They may have a poor work history and absenteeism, or they may be angry with family members who've told them they need treatment. Many patients with substance abuse have a history of poor nutrition, sleep difficulties, liver damage, hepatitis, and other problems stemming from their substance use. Each patient's nursing diagnosis will depend on their physical health state, but may include imbalanced nutrition, risk for injury, diarrhea, activity intolerance, and self-care deficit. Outcomes may include the patient will abstain from alcohol and drug use, the patient will express their feelings, the patient will accept responsibility for their own behavior, and the patient will establish an effective aftercare plan. Interventions include education for both the patient and the family, the substance, its effects, and recovery. The nurse may also need to dispel some myths about substance abuse, such as that it's a matter of willpower, they aren't alcoholic if they only drink on weekends, they can use socially, or that they can handle the occasional use. Patients and family need to be taught about relapse and what actions to take. The nurse may need to address family issues, such as codependence, and teach coping skills. The effectiveness of substance abuse treatment is based on the patient's abstinence from using substances. Older adults who have problems with alcohol abuse likely had a drinking problem earlier in life, had a period of abstinence, and began drinking again later in life. However, 30 to 60% of the elderly in treatment programs began drinking abusively after the age of 60. Risk factors for late onset substance abuse include chronic illness that causes pain, long-term use of medications like anxiolytics or sedative hypnotics, life stress, social isolation, loss, grief, and an abundance of discretionary time and money. The elderly may experience physical problems associated with substance abuse more quickly than their younger counterparts. Many of those getting treatment for substance abuse do so in community-based settings such as outpatient care, freestanding substance abuse treatment facilities, through self-help groups like AA, agency-supported aftercare programs, counseling, or their physician's office. Increasing public awareness and educational advertising have not had the intended effect of decreasing substance abuse in our country. Currently, two populations have been identified for prevention programs: older adults and college-age adults. While older adult alcoholism is usually milder, it also tends to be overlooked by healthcare professionals. Using a screening tool in the primary health setting can help locate these people. Health professionals have higher rates of dependence on controlled substances and alcohol than other professions. While it may be difficult, we do have an obligation to report suspected substance abuse as it's serious and can endanger our patients. Some general signs that may indicate substance abuse include poor work performance, frequent absenteeism, unusual behavior, slurred speech, and isolation from peers. Some more specific signs include incorrect drug counts, excessive wasting of controlled substances, increased reports of pharmacy error, unexplained absences from the unit, and trips to the bathroom after contact with a controlled substance.